and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics is published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor of the series here at Elsevier, and for our 16th podcast, we will focus on the December 2024 issue on management of biliary disease. As the editors write in their preface, as surgery has become more subspecialized and fragmented, the opportunity to remain widely conversant in biliary disease has become more difficult. Our hope with this issue of Surgical Clinics is to provide a general resource and framework to the practicing general surgeon that will help in the management of these often difficult problems. Here to discuss 4 articles out of 13 from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editors of the biliary disease issue, Drs. Nick Manguso and Randy Zuckerman, both in the Division of Surgical Oncology and Hepatobiliary Surgery at the William N. Pennington Cancer Institute in Reno, Nevada. Welcome to all 3 of you, and over to you, Dr. Martin.
Thanks, John. Appreciate it. Nick and Randy, good morning. Good to see you again. I know you got some time constraints, so we're going to try to work our way through this conversation. We've got 4 articles to go through, and first, thanks to you and all your colleagues for putting out a fantastic issue of the Surgical Clinics. This is all on biliary. We've got 2 we're going to discuss today on various carcinomas and 2 on difficult gallbladders and bile duct injuries, but we're going to dig in initially, I guess. We'll start with gallbladder cancer. So, Nick, you've got a great article in here from Waller and Seipel from BI Deaconess and Sinai. And gallbladder carcinoma, to me is one of those topics that's got a lot of breadth because when people suspect it up front, it goes one set of patterns, and a lot of it gets found because nobody suspected it up front. Most of the gallbladder carcinomas are adenocarcinoma of the gallbladder, right? There's a few others here and there. Walk us through your thinking of how you approach these differently when you have some suspicion of it preoperatively versus when somebody gives you a call because they've wandered into a gall bag that went sideways or the path comes back the wrong way.
Yeah, so I think anytime you have a suspicion of it, I think you got to be really thoughtful about how you're going to approach that. And you want to do your full workup. So I tend to be pretty aggressive with, CT scan and or MRCP, really try to get an idea of what's the extent, what is the suspicion, is this all just really bad cholecystitis, or are we truly dealing with a gallbladder cancer? And then I think, if you have a mass that you're seeing on your imaging, then I think it's very prudent to try to get your diagnosis. And that can sometimes be tough because you're dealing with a hollow organ in the gallbladder, and you obviously want to be careful about how you go about biopsying that, not causing problems with things like, leakage of bile and stuff within the abdomen. So I usually will do my imaging, and then if there's a target to be able to be biopsied, a mass growing into the liver, then certainly try to do that either with interventional radiology, or sometimes we need to do it in the operating room, and then start making decisions based on, what the extent of your disease is and what your operation is going to require to be able to get your R0 resection. As opposed to when you find this, incidentally, or gallbladder got taken out, and then you get a call, hey, the pathology came back as a T2 lesion. So those, I think, are really, then I start going back and looking at the op report. Was there bile spillage during it? Did they get into the gallbladder? What's your margins look like? What's your cystic duct margin? So if they didn't give you a report on that, I think you need to go back to your pathologist and ask them to look at that cystic duct margin, because all that stuff really guides me in whether or not you need to put them on some systemic therapy before I think you go back and do your resection, depending on what the extent of your disease is. In any of these patients, I always just have a very high suspicion that you're going to have occult metastatic disease or peritoneal disease. So as the author stated, I'm a huge proponent of, diagnostic and staging laparoscopies in these patients, because I think a lot of them will have peritoneal disease that you're just not going to see on your imaging. And you obviously want to save yourself from doing a big exploratory laparotomy in a patient that you get into, and then all of a sudden you're dealing with peritoneal disease, and you're not going to help them with surgery.
Let's say that somebody gives you a call, they've done an ultrasound, they find somebody, and they're concerned that the gallbladder wall has more than just inflammation. What's your preferred workup in terms of evaluation for that? Are you a CT plus guy, MRI guy?
I start with the CT plus, so I'll get a 3-phase CT. That's usually where I'll start and use that to kind of guide me. The MRI, especially if you're worried about, is this thing climbing up onto the bile duct, or are you dealing with, obstructive jaundice or pending obstructive jaundice, then I'll push for an MRCP or MRI. But a 3-phase CT, I think, is a good start in these patients. That'll give you a good look at the vasculature also, which is kind of gonna tell you where you might have to go operatively if you're thinking that this is going to be resectable, or if you're going to attempt resection in these patients.
So what are your criteria for resectability?
So I think in the upfront setting, criteria, obviously you don't want, I will not take anybody up front if they have any vascular involvement, or if it's close, especially to that right portal pedicle. And then if they come in with jaundice, I favor giving them some upfront systemic therapy rather than taking them to the operating room, because I think you don't know at that point whether is this climbing down into bile duct, or is this just nodal disease or something that's pushing on the bile duct. I think that can be very difficult sometimes to discern when you're seeing these patients that are jaundiced.
Well, I think, and that brings up a question. I mean, sometimes you've got, gallbladder cancer with extrinsic compression, sort of kind of giving you jaundice the way you get from Ritzy syndrome. And other times you get it from direct growth into the confluence. But in terms of if you find enlarged nodes, identifying those lymph nodes outside of the operating room can be a bit of a challenge. What's your criteria to decide if nodal disease is really big nodal disease, small nodal disease, or actually M1 disease preoperatively?
So I think that on your CT scan, if you're seeing large nodes, then you have to presume that that's going to be, nodal disease. And if you're seeing those up into the area of the celiac artery, or any, of the pericaval or periaortic nodes, then I think now you're starting to talk about M1 disease. Anything around the porta hepatis is still going to be within just your regional nodes. But I think if you have any question, that's where I think you can gain some value with a PET scan. So if you're seeing nodes that are maybe borderline size wise, then you may get some help from the PET scan on that. And if I see a patient that has a PET scan that's consistent with nodal disease, I think you have to think about whether or not those patients may benefit from some neoadjuvant therapy, even though I know that there's not strong data around that, but we know how aggressive these can be. And so testing their biology, I think, is something that I like to do in these gallbladder cancers, because they can just be really aggressive, and then you're not going to help them with surgery.
Yeah, I think one of the dilemmas comes up is when you've got borderline enlarged nodes and you haven't secured a primary diagnosis yet. That's always kind of trouble. Back in the olden days, when Rossi and I were first looking at this, we were sort of took a lot of heat for talking about T2 gallbladder carcinoma, because I think pretty much everybody knows that T1 carcinomas, you're kind of done. You can kind of take out their gallbladder and you're probably pretty good. To be honest with you, T3 and T4, I think adding more operations in is frequently not super helpful, although maybe we can talk about that. But I think when it comes to the T2s, especially the T2Bs, non-biliary surgeons, people who don't do a lot of open gallbladder operations, don't really seem to understand how going through the wall of the gallbladder is different depending upon which way you go through it, whether you're going into the liver or into the peritoneum. So I guess, first of all, the big question usually comes up. Somebody's been resected, had their gallbladder taken out. The margins are negative, but is P2B. Are you going to go back and re-resect all of them?
I would say I would hedge on the side of resection if you're not seeing any evidence of metastatic disease, if this is a true T2. And then the other part of that is that I do think that you want the prognostic information of the nodal status. And so if you're going to go back to do a portal node dissection to get those, then you're probably not adding much by taking, a margin of liver there in the gallbladder fossa and somebody that's otherwise healthy and can tolerate that operation. So in the T2s, that especially the ones that you see on the liver side, I think going back and resecting them, and on the T2s that are on the peritoneal side, I think that's really the question, because that's that your margin's already taken. There's not really a margin to get on the tumor side of that. So, I think it's not entirely clear, like, what is the advantage of going and resecting the liver in a patient that has the tumor on the other side, on the peritoneal side. I think you have to be thoughtful about that and what the patient's going to tolerate, because, I think those patients do benefit from systemic therapy. And that's probably where a lot of the survival benefit you're getting nowadays is with the systemic, not with the surgery, especially on the peritoneal side.
Rossi's and mine's point was, a preoperatively suspected T2 tumor has a much better outcome if you go in and do an oncologic operation from the get-go than one that's found incidentally and you go back after. But the other thing we found is that, and we did a batch together, but I've done an awful lot since, obviously. I don't know that I found anybody with disease in the liver remnant that I've resected after a T2 tumor. I've never seen one path report come back positive on the liver part. And to be honest with you, I'm not sure if I've had any nodes come back positive. So have you found on re-resection that you've got a lot of N1 disease?
No, I think a lot of times you're going to pick that up on your staging. So that's going to raise your suspicion. And I agree. I think you don't find a lot of nodal disease. And I also think, when these are resected without oncologic intent, if they get that node of Callot, that's going to give you a little hint of maybe what's going on in the nodal basin. I don't think that the re-resection ends up telling you a lot. Usually you're going to know when you're in there whether or not this thing actually was growing into the liver. But if it's a true T2, your margin's probably going to be negative. So I think there's still a lot to do on whether or not we actually help these patients with those types of operations when you go back after it's been resected and you're finding it kind of incidentally after a cholecystectomy.
Yeah, I mean, I wish as a larger group, I wish we'd actually break that out, because if you look at most of the survival curves, they're lumped together. Yeah. The ones that went with preoperative intent, the ones that didn't. But I think it really gets back to your point that, I mean, this is a systemic disease. And I think we're going to find out, like at pretty much every other cancer we deal with, that local regional control is not enough for many neoplastic processes. So where are you right now in terms of what your recommendations are for systemic therapy? I mean, you basically got capecitabine, and I guess is probably the most commonly used, but there's also immunotherapy out there, which I have mixed feelings about. What are your thoughts on that?
Yeah, I think, in our practice, I would say we're pretty aggressive about systemic therapy. I think that, the data tells us that certainly these patients should go on to adjuvant therapy that have had R0 resections or even R1 resections should get, at least capecitabine for 6 months postoperatively. But I do think that, with the introduction of immunotherapy in this, in biliary tract cancers, I think being aggressive with that can give you a lot of information. We certainly use it in the neoadjuvant setting when there's any suspicion that we're dealing with something more than just local disease. Because again, it's like you said, this is a systemic disease. And so if you're not going to get systemic control, then you're really not going to do much for them trying to get local regional control. And then you're just talking about a big operation that just slows down your ability to get them onto systemic therapy. So I think that that's where, we'll gain improvement in outcomes in these patients is really with the systemic regimens and hopefully with more data that will come out and what that regimen looks like.
Yeah. And again, just to reinforce your point, I don't think there's anybody that doesn't believe that staging laparoscopy is required. I think everybody's on board that you've got to start out there, because as good as our imaging is, there's still probably, about a 20% chance or so you're going to find something unexpected. I can't think of too many reasons why I would just bypass laparoscopy anymore in this situation. I mean, I guess if you had something absolutely you had to unobstruct and you were going to operate no matter what.
I agree with you. I mean, we put a camera in everybody, and I think it doesn't, maybe it adds 15, 20 minutes to your operation, but it may actually cut 4 hours off of your operation because you find peritoneal disease. And that's not, 20% is not an insignificant number. And I think a lot of these patients, you get a cholecystectomy, you have a tumor in there, you go back and look, and you get in there and you see disease over the diaphragm, or you see peritoneal disease somewhere, and those patients really benefit from not getting a big incision to discover that. So I think it should be done in every patient. And even if the laparoscopy was done, this patient sent to you, the general surgeon took out the gallbladder, you found a tumor, I still do it, even if the scan suggests that there's nothing. And sometimes if there's something that I'm at all suspicious about, I will put a camera in them before we start any sort of systemic therapy. So even if the plan is to do systemic therapy first, I will still schedule them and do a diagnostic laparoscopy and a staging so that we have an idea of what things are like before they start therapy. Because if there's peritoneal disease, they really should never get an operation. But we know that some of those patients will respond. I still don't think that they're good candidates for an operation. So you need to find that, I think, before you start treatment.
The other side of this is one of the other articles that we're going to talk a little bit with Randy is on cholangiocarcinoma. And this one was from Doctors Harrison and Visser from Stanford. So cholangiocarcinoma, we're really into much the same discussion, because I kind of look at gallbladder carcinomas, maybe wrongfully, it's just one more neighborhood in the neighborhood of biliary carcinomas. I think for the sake of, as you know, a lot of our listeners are trainees or younger people, but to me, there's really, we're into the real estate discussion first, which is their intrahepatic tumors, extrahepatic tumors, intrapancreatic tumors, for lack of a better word. And then I'd say gallbladder, which we just had a discussion of. Location drives everything, don't you think, on this?
Correct. So, cholangios, I think of really in three ways. So you have the intrahepatic or peripheral cholangios, which I think of almost as a different beast than the ductal cholangios. And the ductals, I really think about hilar versus distal cholangios. And they're all, I think about all of them differently, though none of them are a great thing to have. So they all come with various associated troubles. So the intrahepatic cholangios are treated very differently than the ductal, the more distal ductal cholangios, with the hilars being the most confounding.
So, from my standpoint, when we look at anything that's below the intrapancreatic portion of the bile duct superiorly heading on down, we're just basically having a discussion about periampullary neoplasms, classic pancreaticoidectomy stuff, which is kind of part of what this is, but not the main focus. And when I look at the intrahepatic ones, the further away they get from the hilum, the more it is, well, if you can get rid of the liver that holds it, all good for you. So you really get into like the hilar tumors, as you discussed, and then the extrahepatic ductal tumors. And I may be alone in this, but I don't actually believe in Klatskin tumors in the classical sense. Klatskin tumors are almost invariably a tumor that started somewhere but grew to block off the confluence. I guess statistically, some must be able to start right at the confluence, but it always seems to me like they're coming out of one side of the liver or the other, don't you think?
Yeah. So just to back up to the ones so I agree with your assessment of this. If they have a periampullary or a distal cholangio, they're getting a Whipple if they are a candidate. The only thing I hate is that for a pancreatic cancer, I am to the point in my life where almost everyone sees neoadjuvant chemotherapy. We're not doing that for cholangios because we don't have great chemo. And it's really hard to extrapolate like Topaz data to a pancreatic periampullary. But what I also will tell you is we've done a bunch of Whipples for things we thought were cholangios that ended up being pancreas tumors. And then I wish I had given those guys chemo, but there's no way to sort it out. For the ones in the liver, to me, the only confounding factor is a lot of times you'll look at a scan, you'll see a tumor, you put a laparoscope in and they have multifocal disease, which to me is out of bounds still, though we have downstage several patients with gem, cis, and durva and got them to a point where we can do something to their liver. And then you have the ductal cholangios, and I sort of agree with you, like the tumor starts somewhere, But once it involves the hilum, as you know, it just makes surgical approaches really difficult. Your options are you can take out the bile duct, problem being that these tumors love to spread submucosally, and so it's really hard to get a negative margin. I've sort of come to accept that liver resection is required for most of these, and a lot of times you end up doing big liver resections. I am unsure in that I've made anyone live a really long time from doing that to someone, though I certainly have kicked the can down the road. God, I sound like an old circumspect guy, but it's all just based on doing this for a long time. And every once in a while you'll get, a cholangio that you get out with negative margins, but the problem with the hilar ones is then you have to start worrying about vascular involvement and vascular reconstruction. So, if I see a hilar now with where I'm worried about portal vein invasion, I will often give those guys chemo up front, which may or may not work, and B, send those somewhere where there's transplant availability, because those vascular reconstructions that high up are really, really hard.
And I think that brings me to the next point that I wanted to discuss about this, because I think especially for people that don't do a lot of this like we do, or that, or haven't been around it as much, the concept of oncologic operations is difficult for a lot of people to grasp. But part of it is to get around a tumor widely in some respect. I mean, as a general principle, whether it's really necessary or not, kind of depends. I mean, it either becomes unnecessary if getting around it widely doesn't matter, or getting around it widely doesn't help. Like, we don't try to get widely around lymphoma anymore because we got ways to treat it. We don't try to get widely around ovarian cancer anymore because we got ways to treat it. But as you brought up, we don't have a lot of good ways to treat cholangio at the moment. The closer you get to the hilum, and where the portal triad is still a single triad, and the closer you are to the structures in the porta, the harder it is to get away from the vessels, right? So it all becomes, to me, hilar tumors, they combine like the two separate problems of, one, can you separate it from the vessels that supply blood flow to the liver? And two, can you take out all the liver that had cholangiocarcinoma in it? Whatever that is. It may be none. I mean, if it's really, at the confluence of the ducts and magically just started there and turned somebody jaundiced, and I haven't really run into that in my life. It's usually going up one duct to the next, as you say. And if you're chasing the wrong duct, that makes for a bad day. The questions really is like, how do you decide that you can separate this from the vasculature, or at least enough of the vasculature, and keep things going? I mean, what are you using to assess that? Again, is it triple phase CAT scan? Is it MR?
Yeah. So I think I'm using all of it. So all of these patients I see will end up with a good pancreatic protocol CT. They all will get an MR. Many of them are most of them are getting EUS. And I'm liking Spyglass for this now, because I feel like we can get a sense of which side it's going up, though it's certainly not perfect. I mean, I think everyone's getting all of it, and then the decision making is still difficult sometimes.
So we didn't really talk about local therapy, like, TACE and TARE and things like that, but what are your thoughts on adding that in?
Yeah, so for the intrahepatics, I sort of like local liver-directed therapy when possible. I like Y90, though it's really hard to get it approved for this, though I've had anecdotal experience that it works quite well. We will ablate small ones in patients who are bad operative risks. We have recently acquired a histosonics machine. There are some cholangios that are on our radar screen where histosonics would be a reasonable option. But I think it's sort of all on the table, though my preference is, resecting these if possible. However, we're seeing these in 90-year-olds and in, not everyone is really up for a hepatectomy. So I think having other tools in your bag is helpful.
I mean, we had that discussion with Samir Patel a couple of weeks back. It may not be out for the listeners yet, but it'll probably be out before this one. But, one of the things that people still confuse is resectability and operability, and they should never be confused. And as you and I know, we've worked together in different places and been doing this for a long time with each other. But, resectability is about the tumors and operability is about the patients. And a lot of our colleagues who send people to us just don't get it. I mean, let's face it, some people just aren't up for a haircut, and other people you can do just about anything. The role of transplant for this is interesting. We had another discussion about that a couple podcasts ago. But I do think that when you get down to the point where you can't guarantee the blood supply, I mean, you can certainly take blood supply away from liver, right? But you can never have an undrained biliary segment.
Right.
We're going to get to that when we get to the difficult gallbladders and injuries as well. But that's another premise that our young readers and listeners need to remember. Every segment of liver must drain bile or it's trouble. And for systemic therapy for these, what are you using these days? What are you liking?
So we've been using the Topaz trial, which is GEM, CIS, and Durva. We have seen some responses that I would not have predicted, like incredibly dramatic responses in some young patients, like responses that I think we did not see prior to Topaz.
Okay.
So, yeah, but it's not so easy on humans. And so, again, you have to be fit and able to tolerate it.
Well, we've got a couple other articles we need to get to in the time you guys have left. Randy, why don't we stick with you for a second? Because I think dealing with a difficult gallbladder lends into the bile duct injury parts. Yeah, as we both know. So there's a nice article by Murray and Babineau from UT at Tyler looking at the difficult gallbladder. So I guess the first thing is my experience has been is that people wade into difficult gallbladders without really realizing what they're doing more often than not. Whereas people who have to fix the problems that come from difficult gallbladders generally don't fall into these traps. They kind of see it coming.
Yeah, I think that's perfectly stated. But just to back up, so this chapter was written, one of the authors was Hugh Babineau, who was my co-chief resident and who is a bariatric surgeon who also does a lot of acute care surgery. And like one of the wonderful things about this series, editing it is, you end up reconnecting with lots of people you've known from lots of phases of your life. So thank you for that opportunity. If I am doing a difficult gallbladder, the only thing I am really thinking about is how do we not hurt the patient's common bile duct? Because that's a disaster. And somehow, like this idea that you have to get the whole gallbladder out all the time, or you can't put a tube in a gallbladder, or you can't give someone antibiotics, or it has to be done in the middle of the night. Like the only thing you really can't do is hurt the common bile duct or common hepatic duct, because as you know, it's a disaster, it's difficult to fix, and patients can have lifelong problems. And we repair a lot of bile ducts.
Yeah, and sometimes those lifelong problems don't last that long for the reason that neither does life, depending on how
Correct.
When, again, not to keep going back to Rossi and I, but I started out my career basically wandering around the globe talking about bile duct reconstructions because laparoscopy was just starting and it became a cottage industry to put bile ducts back together, which has since settled down a little bit, but it has certainly not gone away. Our sort of working theory at the time was that all bile duct injuries had some things in common. There was either difficult anatomy, difficult pathology, or difficult surgeons. I think we actually call it dangerous anatomy, dangerous pathology, and dangerous surgeons, is I believe what we actually wrote in the surgical clinics back then, long before I was the editor. And I don't really see after almost 35 years, I don't really see any reason to change my opinion on this. I still think it's the same thing. I think people have become facile with laparoscopes, and they really don't see that anatomy or pathology is a hindrance to their world. And I don't really agree with them.
I can tell if I'm doing a hard gallbladder, I can tell in about 2 minutes how it's going to go. And if it's going to be exceedingly difficult, I think about it in very different ways.
Right.
If I get called to the OR and I see someone who is dissecting well below Rovier sulcus, I'm like, stop, and I think there are some really simple anatomic things that can help keep you out of trouble. I do think that immunofluorescence is being useful, Firefly, in helping people sort of see what's what. But But as you know, the incidence of gallbladder injury has not really changed in the last 20 years. And so same problem over and over.
Well, and I think the thing is that, cholecystectomy in military equivalents is a minefield.
Yes.
And you must have a plan as to how to get out of it if you found that you've wandered into it.
Yeah.
And the difficult gallbladder is a really densely filled minefield. There's a lot of different ways to make things worse and not very many ways to get out. But I think some of the points you've already brought up, I think there are not very many good reasons to do a bad gallbladder in the middle of the night.
Correct.
With either subadequate resources or subadequate assistance. I think too many people are too hesitant to get another experienced surgeon in with them during the case for whatever their emotional reasons. If you're not making progress and things aren't going smoothly, you should be asking yourself, what am I missing? What's not going right? Maybe I should get another pair of eyes if at all possible.
Yeah.
So that's one thing. And I think people miss milestones and time to progress. They just think if they just keep plugging away, everything's going to be okay. And you find out they're plugging away on the wrong side of the common duct or too high or what have you. So I do think that there are some things. I think one thing I might take issue with the authors of this particular chapter is I still think that conversion to open should not ever be considered a failure.
Correct.
I struggle with, and while I'm not opposed to subtotal cholecystectomy, and I'm probably not going to get a lot of support on this one from a lot of people, if you can get a gallbladder out safely open, that's better than doing a subtotal cholecystectomy laparoscopically, especially if you don't really know how to control the subtotal cholecystectomy.
I actually like subtotal cholecystectomy because I think it is safe and it avoids bile duct injury. I think that there are a lot of younger surgeons who probably can't do much better open than they can laparoscopically or robotically. And I will say that the incidence of injury and conversion is also not trivial for many people. I think there are some people who can take a case that might have been a laparoscopic subtotal and convert it to an open complete cholecystectomy. I think there are a lot of people who will also do an open subtotal. So I never think opening is a failure, but I think the utility of open surgery for many people is likely no better or perhaps less effective than they are minimally invasively given today's training.
Yeah, I mean, I take all your points. I still think, though, that there's a lot of things you can do where you can stop doing what you're doing and then get the patient. Just because somebody's not capable of doing the best thing doesn't mean everybody's not capable of doing the best thing.
Correct.
And I think you mentioned briefly, if you're really in that big of a jam, depending upon what's going on, just putting a drain in the gallbladder and stopping there and saying, I need to either get better help here or send the patient to someplace with better help. I think that's a better choice because I've had to complete or deal with the consequences of a lot of poorly done subtotal cholecystectomies in my career. And granted, the three of us are biased because nobody sends us their successes.
No, and if you look at like the Safe Cholecystectomy Project, one of the big things is call for help.
Right.
And if I am doing a gallbladder and I can't figure out what's going on, I will call one of my partners and say, hey, I think this is this, this is this, this is this. What do you think? And sometimes I'm right and sometimes I'm wrong. But I think calling for help and trying to understand the anatomy, because again, if you have difficult anatomy, nothing's where it should be. Yeah. And you can convince yourself that stuff is where it should be, but that's when people get into trouble.
Yeah, and Stewart and Way used to write a lot back in the day about this confirmation bias in how people convince themselves they're doing the wrong thing. Sometimes that argument was used, and I'm not pointing this at Stewart or Way, but that if you convince yourself you're doing the wrong thing, you really didn't do anything wrong by doing it. I think that's a little circular. I think if you convince yourself you're doing the wrong thing and you do it, you're on the hook for having done it wrong. But that's kind of a legal argument more than a medical argument. But I do think that when you don't know what's going on, your point up front is don't make matters worse.
Honestly, I would rather, I sort of like, if you're going to do a subtotal, I like fenestrating because most bile leaks can be managed pretty easily with stents or covered stents.
Right.
I have had to take back some patients who have had reconstituting subtotals or partials or whatever. Honestly, I would much rather do that than have to fix someone's bile duct injury. I think that's why I've shaken out, like, after a lot of time saying, you know what, if you're in trouble, just do a subtotal.
Yeah, I hear what you're saying, but I would say if you're in that much trouble, put in a tube and stop.
And I think that is actually way better. Not many people do it. And it's like I think people feel like they've really failed, whatever. And honestly, they've just done a really safe thing.
But to me, the thing is one has to understand why you're in that situation to begin with. Right. Not because it's like somebody has a gallbladder excess. It's like, oh, I was born with an extra gallbladder. One needs to go. No, somebody's there because they're sick. And generally speaking, if it's a horrible gallbladder and their bile ducts aren't jacked up, then it's because their gallbladder's pressurized or filled with pus or something, right?
Yeah.
And if you get the pressure off and the pus out, you've achieved your goals of keeping the patient alive to fight another day.
Right. But like when we get called to fix things during injuries recognized, 95% of them, it's after hours.
Well, of course.
Yeah.
That's how it goes. Speaking of which, so moving on to the last of them, this kind of lends us right into it. So the last chapter is from you guys, okay? The good doctors Manguso and Zuckerman, about, identification and management of bile duct injuries. And again, the topic this is my last podcast. This is my last article to review. So I appreciate that. This is the end of my time here. But we're starting on the thing that started my whole career off. I think one thing is when it comes to bile duct injuries, essentially 100% of them are iatrogenic, right?
Yeah.
So, occasionally, I've had people shot or stabbed or have rocket fragments or something go through their livers and stuff overseas, but almost every bile duct injury I've ever dealt with is from iatrogenesis imperfecta. Just something's gone wrong that somebody didn't see. And I would say that the overwhelming majority of them are also preventable.
I think going back to what you guys were just discussing, which is it's really, when you are uncomfortable with what you're seeing from an anatomic standpoint, that is where you have to make the decision to realize that you're getting into territory that could cause a lot of problems. And that's when you call for help or you open. And, to your guys' point, not every gallbladder has to come out at the index operation. You're trying to fix a problem of infection. And it's not a failure to say, we can't identify this anatomy. We got a drain in it. We're going to get them better. We'll take our bogey and live to fight another day. And so I think a lot of these arise because of the difficult gallbladder, and you have to have bailout options. And it was always described to me by a mentor as some surgery should be described by what you don't want to do. So a cholecystectomy should really be described as don't injure the common bile duct, because those are the things that really get you into a lot of problems for patients. And again, these, often they're fixable and you can get them through it. But some of these patients deal with this lifelong, and it can affect mortality and morbidity and quality of life. So you have to be very, very careful in this area.
Yeah. And on top of that, last I knew, it used to be like misdiagnosis of breast cancer was the thing that beat most surgeons up. But now it's most general surgeons, their biggest fear in life is the lap chole gone bad. That's the one that rocks people to their core. And some people leave the business because it's just, it crushes you emotionally. But I think, so in terms of just describing the types of industry, I think the most common descriptor set is the one you guys put in your article, the Strasberg, which, to be perfectly honest with you, no disrespect to Strasberg, I don't like that classification. Basically, it reminds me of the kind of thing you do as a boards examiner to ask like incredibly complicated questions regarding memory. Because to me, it's like all the lettered ones, all the non-bismuth pieces of it are really just like the same thing. They're just like a bunch of leaks. And the numbered ones, it's just bismuth classification, which is the closer you get to the confluence, the worse life is, in terms of fixing things. So we could really make it simpler. But, and when I was writing about this in the old days, we sort of made a big deal about the fact that there are leaks, there are lacerations, and there are transections. To me, that changes the whole world, because the leaks, as sort of Randy alluded to earlier with stents and so forth, there are ways to turn the pressure off to a leak, and a lot of them will just seal up.
Yep.
So if you look at Strasberg's original set of classifications, other than sort of an accessory right hepatic duct leaking or something like that, the rest of them are just leaks. If somebody's got a laceration, it kind of depends on what's left of the duct, right?
Yeah, I mean, I think that's a really good point, which really, when you think of these from a clinical standpoint, it's how close are you to the hilum and the bifurcation, and where's your injury in that respect? And everything below that usually is, like you said, it's a leak that can often be addressed. Or, when I think about it, I'm thinking, how close to the hilum am I going to have to be to get to healthy bile duct to be able to fix this problem? And things that are more distal to that tend to obviously be a lot easier to take care of, because you're not way up at the hilum trying to dissect out the bile duct, trying to figure out where your injury is. And that's really, when I think about these, is where what you really need to differentiate. It's like, how close are you going to be to that right and left duct when you're going to have to be in there trying to fix it?
Yeah. And I think the part that kind of goes unspoken, for people like us, but a lot of people don't think about, is how much blood supply to the actual duct got damaged. The idea of people sort of doing these immediate reconstructions or closing their own gaping holes, and they may be just setting somebody up for the stricture down the line, so this got to be thought through. I take the point of the classification scheme, but I just think the simpler view is if things are leaking and the bile duct still has perfusion, decompression alone may get you where you're going, as long as every segment drains to the GI tract somehow. If things are lacerated, like when you get these accessory right hepatic duct lacerations and associated with bile duct injury, it goes back to what we were just talking about. And then if the bile duct's been disconnected, it's either wide open or it isn't, and the level, that kind of brings it up. But which brings us to the recognition of injury, because to me, and you tell me if you think otherwise, the big difference is whether this is recognized in real time or not.
I think that's critical. And I think, to your point, evaluating your perfusion is important. And that, I think, is also one of the other arguments of delayed repair, is you get a little declaration of what is going to maintain perfusion, so that you're not fixing a bile duct that is only going to stricture on you in a couple months when the ischemia sets in. But time of recognition, I think, is critical in how you plan to fix these. And so I think we are, in our practice, in my mind, if you're more than 48 hours out from recognition of injury, this is not going to be we're taking it to the OR tomorrow to fix this problem. This is going to be we're going to let everything settle down. We're going to get drains where they need to be. We're going to let it declare itself a little bit, and then we're going to come up with an operative plan on how we're going to fix this. And I think I've encountered, when we've had this problem, a lot of people in the community who are a little shocked by the fact that we're not rushing right back to the operating room. These things, I think, need over 48 hours is really the cutoff point in my mind. And then it's just time, and you got to get them optimized nutritionally. You got to recognize what their anatomy is going to be. And then you go back when your acute inflammation has settled down a little bit, and you have a better shot at really getting to healthy duct and being able to do a good quality repair that's going to hold.
Yeah, I mean, and to that point, let's just take a moment or two and talk about evaluating these people post-op. I mean, so let's say that somebody operates on somebody, they don't realize it, and then they come back sick. To me, let's assume they've got an actual bile duct transection for the sake of argument. They come in two kind of flavors: those who come back sick and jaundiced, and those who come back sick with a belly full of bile. I mean, there's other, obviously, variations on the theme, but to me, they're different. And so, people are forever doing things like getting ultrasounds and HIDA scans, and I don't get it personally, because we know that if you just took a bunch of people who are doing fine after taking their gallbladder out, they're going to have fluid where it doesn't belong on ultrasound. They're going to leak bile from the gallbladder fossa on a HIDA scan. So, yeah, I mean, CT maybe for a giant biloma, but to your point, the question is what's the status of the anatomy? And I know that people get MRCPs, which I think are a lot more useful in the person who's jaundiced. And ERCP is probably a lot more useful in the people who aren't jaundiced.
No, I agree with that. I mean, I think that the people that are jaundiced, the MRCP helps you, in a sense of trying to get a little bit of idea of where you're seeing your cutoff at. And then to me, that's a lot of decision making on, okay, do these people need, a transhepatic biliary drain in place to decompress them, to get them to a point where you're going to get them to surgery. And then, I like the ERCP because I think it gives you a little bit more clinical information, right? You're not just getting a scan, you're getting a good cholangiogram. You can have a little bit of an idea of maybe it's just a small, it's a leak from the cystic duct and you're able to stent it and you can address that problem. But I think it offers you the opportunity to see what you're dealing with. Is this a transection or an occlusion, or is this just a leak? But also you have an opportunity at that point to do something clinically that potentially gets the patient through that without a big operation that they may not need. So, I think my experience is that in certain places, a lot of the GI doctors like the MRCP. I'm not sure, what it adds to if you're already going to do an ERCP, but
it adds 6 hours of sleep. You can get an MRCP in the middle of the night. You're not getting an ERCP until they feel like doing it. And right. I don't necessarily blame them, but to me, when you get the ERCP that shows you like a cutoff near the top of the pancreas with 2 staples, it's like, okay, now the game's afoot. Now they've either got a belly full of bile or they don't.
Yeah.
If they got a belly full of bile, you probably just, I don't know, you tell me if you're wrong. I mean, I think that's a good case to put some drains in it and cool your heels and do exactly what you described.
Yep.
If they're jaundiced and there's not a belly full of bile, then an MRCP hopefully will give you the level of injury. And again, it'll be out of, and again, I'm not trying to pick on Strasbourg. I don't want any hate mail from Strasbourg fans, but the leaks are all out of the equation now. So now we're just into what's the level of obstruction. And you can have more than one, obviously. I mean, I've seen some pretty horrific ones, but I think that at that point, you're really trying to determine your anatomy so that you can plan your definitive reconstruction, hopefully in one setting, correct?
Yeah, exactly. So that's the biggest thing, I think, with the MRCP. When there's a clip across it, you don't have a belly full of bile, you're just dealing with jaundice. Then to me, it's all operative planning. Like what are we expecting when we go in there? And it may not, give you the exact location, but I think in these types of cases, they can be very, very difficult. It can be very difficult to find the bile duct and get around the bile duct. And so if you have a little bit of an idea of where you're going to be working or where you're going to have to work in this operation, that preoperative planning, I think, is really critical in trying to fix this problem in somebody.
I'm super simplistic about these things. I really want to know, how high is it? Am I doing 1 anastomosis, 2 anastomosis, and does the patient have a right hepatic artery?
Okay, and what will you do if they don't have a right hepatic artery?
I will still reconstruct them. I would really want a PTC through my anastomosis, and I would tell them that their rate of stricture is higher than your average bear, and that this story may not be over.
No, I'm with you. I mean, you bring up another point that I really didn't put in my notes, but I'm glad, because I've been sent a number of these people years later where they had a thermal injury. I mean, especially back in the days when people were using a lot of laser. It's been a while, but they show up with a delayed stricture. And PTC is becoming a difficult skill set to find available. MRCP is good at seeing standing fluid. That's all. No disrespect to the world of magnetic resonance, but it doesn't drain anything. It doesn't put any tubes. You guys can tell me if you agree or not, but I've had plenty of people with difficult strictures, either benign or neoplastic, where being able to advance a wire from the outside through a dilated system in helps you to find a target in an operative area that may be thoroughly obscured by whatever went on before.
Yeah, it's hugely helpful.
Yeah, I mean, I am a huge proponent of them. But again, I agree with you. I think finding people with that skill set is sometimes difficult, and that's, I think, the point that we try to make in that chapter is that if you don't have that kind of skill set available, these patients are better served in a tertiary center where you're gonna have that available, because you need to have advanced GI and advanced interventional radiologists to be able to deal with these problems, because even down the line, if they stricture after your repair, it's a lot easier if they can get a wire across it and dilate that up than it is to go back and try to revise that. And you're just dealing with an area where the anatomy can be tough, it can be really stuck, and you're sitting right on top of the portal vein or the hepatic artery, and all of a sudden you got a hole in that, and then you're in a whole different set of troubles in these patients. Yeah, and you're kind of stuck in those situations. So I try to be real thoughtful about what are our approaches and how can we set ourselves up for success in the operating room when we're prepping to try to fix these problems.
I mean, the common theme through all of these, whether it's the cancers or the bile duct injuries, is don't make matters worse for yourself.
Yep.
And by extension, don't make them worse for the patient, which makes it worse for you. I mean, it shouldn't just be about us. We obviously don't want to make things worse for the patient. But my advice to people, if they're in a gallbladder and things are going sideways, or they think they may or may not have created an injury, if they're not really qualified to deal with it or get the help immediately to sort it through, just stop.
Yeah. Yep. That's what we say. Leave drains and get them over to us. That's it. Yeah. And we'll figure it out from there.
I mean, even in my shop where Randy worked with me back a bit ago, there's a limitation to it. I mean, I'm pretty facile with fixing biliary trees, but if you don't have all the people around with you in the other specialties, you're in a kind of difficult position. You've got to have the right stuff and the right help. But I think it's one of those things that we don't teach people. And on the big surgery level, one of my regrets as I'm looking at the short end of my career now is that we really didn't insist on maintaining a large volume of people with an open skill set for some of these problems. We let the videoscopic approach. We had all these rules back when I was a program director in DME and DIO and all these other acronymic jobs I've had. We had all these rules about how many videoscopic things people needed to do, but very little about maintaining a basic open skill set. Because in 1982, pretty much every general surgeon in this country could open a bile duct and rummage around and feel pretty comfortable. And that's not true anymore.
Yeah, I think your point is really well taken. I think that in today's day and age, and then that's, I think, where you can get into trouble, which is that people feel more comfortable laparoscopically or robotically than they do open in that area, around the porta hepatis with the gallbladder. And so there's a tendency to fight through minimally invasive. And it's, when I get called to the OR to help with identification of anatomy, et cetera, most of the time first thing I ask them is, are you open? Because I think that if you're not, that's the next step. And just bringing me in to look at what you're seeing on the screen, I think, and every once in a while, sure, we're able to delineate anatomy and things go fine. But I find that when I get in there, if you're not open, one of my first things I'm going to say is we need to open. We need to look at this stuff directly. And some people don't feel comfortable with looking at that anatomy from that direction. But I do think, if you're going to do a subtotal, you probably should be open and deciding whether or not you're able to get the gallbladder out. And then your next step is the subtotal. But if you don't feel comfortable in that setting, then yes, you probably shouldn't open and start mucking around, because the anatomy isn't, you can get in a lot of trouble that way as well.
And I think, if you are in the position where you are in trouble, you think you have a bile duct injury, you should never fix it by yourself, both from a emotional perspective, a medical legal perspective. Call in the pro from Dover, and step out of the room and let someone handle it, because you're so emotionally jacked up after injuring someone like that. It's really difficult to be at your best.
I think that's great advice, and I think everybody should take it. I mean, and I think the thing is the people that do a lot of this, like us, really don't have any emotional problem calling in anybody to help and say, tell me where I'm wrong. Because you know, there's nothing more relieving than having one of your partners come in and look at it. And, you know, Nick, to your point, when I was young in the game, I was taught the first thing you do when somebody calls you into an operation that's not going well is tell them they need to make a bigger incision. Doesn't matter what it is. You know, you could close your eyes and say, just make a bigger incision. And because if nothing else, it just buys time. It's like having people going off and boil water to make sheets for babies and stuff. It just buys time. But anyway, well, guys, I think we appreciate your time, and I know you're busy, and we could talk about that. I could talk about this for months, but really appreciate everything. It's a great issue. Thank you so much for doing it.
Congrats on a long run at the helm.
Thank you. I appreciate it.
Yeah.
Yeah.
Well, thank you guys for including us in this. We appreciate it.
Thank you for joining us for this Surgical Clinics podcast devoted to management of biliary disease. The 4 articles discussed, as well as 9 others, are in the December 2024 issue, Volume 104, Number 6. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can find our podcasts on most major audio streaming platforms, including Apple and YouTube. Visit theclinics.com for more details. Thanks for listening.